Okay, I wish to take this opportunity to welcome everyone. And I must say good morning, good afternoon, and good evening to you all. We are about to start in a few minutes. Today's webinar is available only in English. We encourage you to register for the second one, which will be in more than 2 languages. That's Portuguese, French, and English. And it will take place on the 17th of March at exactly starting 8 a.m. Eastern Time. This webinar today is recorded and the recordings will be shared to all participants. Right now, as you can attest, our microphones are all off. Our webcams are also off. They are disabled. And we will now get started with the meeting. I wish to welcome and take this honor to invite Dr. Raj Panjabi, the US Global Malaria Coordinator with the USAID President's Malaria Initiative. Dr. Raj, you're very welcome to have the presentation started.
Thank you, Mariam, and good morning, good afternoon, and good evening. I'm thrilled to be with all of you today as the new US Global Malaria Coordinator. You know, something we're very proud to celebrate at PMI is the work of our partner countries who have helped reduce malaria mortality by 60% and decrease the number of malaria cases by 27% since 2006. These achievements are really the result of global efforts and contributions not only from the President's Malaria Initiative, national and subnational governments, local communities, donors, multilateral organizations, faith groups, the private sector, research and academic institutions, and so many others who share in our dream of a world without malaria. You know, as we get closer and closer to achieving that dream, it becomes more and more essential that we, those of us who work in global health and development, invest in, mobilize, and empower existing networks, resources, and capacity within the communities most affected by malaria. So today, I want to talk about two, what I call superpowers. The superpowers of community and faith. You know, if you think about it, community and faith give meaning to our lives. Community and faith animate the important moments, the birth of our children, loss of our parents, and of course, we can't forget weddings. How could we ever forget weddings? But community and faith can also inspire our work. Over the course of my career as a doctor, I've been humbled by the superpowers of community and faith. I've seen community and faith energize and give purpose to the work of healing and inspire neighbors to carry out incredible acts of love for one another as community health workers. You know, I may have been the student of medical school professors, but it is in fact community leaders who have been amongst my greatest teachers. In fact, a year ago today, I was caring for patients in a community clinic and making home visits with community health workers in the rainforest of Liberia, the country where I was raised. I was in a community called Bo, which is about 2,000 people spread across 9 villages, deep in the heart of the rainforest. You have to walk on and hike through footpaths in the forest to reach various villages. It's a place I've been visiting regularly since I was a medical student. Now, early on in Bo, I heard too many stories of children dying from malaria, a preventable and treatable condition because they had no access to the medicines that they needed. But over the years, I saw how youth and women organizations in Bo relied on the values of service and justice. I saw how they volunteered themselves to become trained as community health workers and eventually to even build their own community clinic. I saw local organizations use the superpower of community to save lives. community leaders made it possible to provide care to patients with malaria and other conditions in a place that was thought by policymakers as too hard to reach and too difficult to serve. Today, half of Liberia's rural children in communities like Bo with malaria get tested and treated by their neighbors, by community health workers. The effectiveness of such community leaders, as we know, is due in no small part to the lived experience and the values that these community organizations, community leaders, share with their neighbors. And we all know their impact on malaria can actually be measured. This is especially true when it comes to encouraging the adoption of malaria prevention and treatment behaviors. Ending malaria, we know, depends on effective tools and systems for sure, but that is not enough. Ending malaria also depends on ensuring that individuals seek care and treatment and use malaria prevention methods. PMI and others here provide partner countries with life-saving medicines, insecticides, and nets, but it is local community and faith leaders like those in Bo that can help ensure those supplies don't sit unused. They work hand in hand with frontline health workers to ensure that families understand the risks of malaria, know how to protect themselves from malaria, and when to seek care and trust in the diagnosis and treatment that they receive. We know that people are most likely to adopt new behaviors, like sleeping under a bed net, when they receive counsel from sources they know and trust, and who understands needs and values more than religious and community leaders. Let me share with you another example, this time from the superpower of faith. One of the tremendous advances in the fight against malaria, as we know, is indoor residual spraying, or IRS. Locally employed spray teams apply insecticide to interior walls of homes in order to protect families from disease-carrying mosquitoes. While it's incredibly effective, it can only work if households, and enough of them, agree to have their homes sprayed. That's why PMI relies heavily on the superpowers of faith leaders to allow access and offer their blessing to encourage communities to embrace indoor residual spraying. One such leader, faith leader, is Reverend Jimmy Max Ayon of St. Paul's Church in Uganda. Last year, he called upon every member of his community to open their house for spraying. Reverend Ayon spoke on radio shows and personally reached out to reluctant individuals through door-to-door visits in his district of Otuke. Since then, he has continued speaking about malaria at funerals, at church services, and at other gatherings because he's committed to ensuring that no one in Otuke loses their life to malaria, especially amidst the COVID-19 pandemic. Reverend Ayon is just one of 102 religious leaders in Uganda trained by PMI and its partners last year to promote malaria control activities in their communities. And thanks to their efforts, we've seen an increase in both in indoor residual spraying acceptance and demand. In Reverend Ayon's district alone, PMI helped surpass its spray target by 12%, which means that Reverend Ayon's work helped protect an additional 20,000 people. Now, this inspirational story of Reverend Ayon and faith leaders like him remind us that the superpower of faith, which is rooted in compassion, is essential to help us defeat malaria. Now, look, the superpowers I'm talking about of community and of faith are not new ideas, I know, to many of us on this webinar today. From the beginning, many of us alongside PMI have made deliberate efforts to work with more than 200 nonprofit organizations to contribute to the development of local capacity to end malaria. And in fact, approximately a third of those are community or faith-based. And about a year and a half ago, in August 2019, PMI invited these faith and community leaders from across Rwanda, Tanzania, and Zambia to develop strategies for launching so-called Malaria Days of Reflection in their respective countries. The goal of the event was to dialogue with and learn from these organizations about the way in which they were already working to prevent and reduce malaria, and to contribute to those efforts by exchanging best practices, ideas, and strategies for continuing such work. Two of today's speakers, in fact, will share reflections on the event. We hope together with you to build on their efforts with the launch of the Toolkit today through continued support for community and faith organizations. I want to thank a few very special people today who will share their stories with us. Reverend Emmanuel Chikoya of the Council of Churches in Zambia, Pascaline Umulisa of the Girls Guides Association of Rwanda, and Dr. Lamine Bangora, PMI's very own malaria specialist at USAID in Guinea. I'd also like to express my gratitude to Anna McCartney-Melstad and PMI's implementing partner Breakthrough Action for all their efforts to bring this toolkit to fruition. And I had a chance to look at it, and it's quite engaging. I encourage you all to look at it, but also for organizing this webinar. I also want to thank our moderator, Mariam, Nabukenya Wamala, and of course, my deepest appreciation to my sister, Joy Phumaphi, for being with us today. Thank you, Joy, and for the leadership and vision of the African Leaders Malaria Alliance. And thanks, of course, to all of you for engaging in this important conversation. I'll end with this. We know from the history of outbreaks that outbreaks start and stop in communities. The toolkit we will be sharing today is an example of PMI's commitment to create resources and opportunities to further engage and empower community and faith-based organizations. I challenge all of us to ask ourselves, how can we do even more to partner with community and faith-based leaders? Ending malaria depends on investing in these leaders and the people closest to those we wish to serve. Ending malaria depends on working with them to reach the unreached. Ending malaria, my friends, depends on the superpowers of community and faith. Thank you.
Thank you very much, Dr. Raj. This has been so powerful. It is so intriguing. I know everybody implementing in the malaria fraternity, this has touched you. We want to thank you so much for this powerful word to everybody. And we also appreciate the support from PMI to all the countries where we are. And we know that we have learned a new terminology from today. We have superpowers. And from here, we are going to pick on this and we use it. Superpower is very powerful. Thank you so much, Raj. So I also want to take this opportunity to welcome Mrs. Joy Phumaphi, who is the Executive Secretary of the Africa Leaders Malaria Alliance. You're very welcome, Mrs. Joy, to present to us.
Okay. Thank you so much. And I'd like to pay special recognition to Raj and to PMI for convening this event, and most importantly, for developing a tool which we are so very excited about, because we know the importance of community leaders and faith leaders. Could I have my slide deck, please? Could we have the first slide? The African Leaders Malaria Alliance is an alliance of all of Africa's heads of state and government. And the current chair of the alliance is His Excellency President Kenyatta of the Republic of Kenya. The aim of the alliance is to enhance accountability for results in the fight against malaria. We focus on the use of scorecards and accountability and action tracking mechanisms at continental, national, and at, of course, regional, and at subnational and community levels. Our aim is to sustain political leadership and commitment to the fight against malaria, and more recently, to engage communities more effectively in the fight against malaria. And in order to accelerate this process, we have been setting up malaria councils and funds. Next slide, please. Now, could I have the next slide? What are the opportunities for engagement with faith-based organizations and CBOs on the African continent? We in our developing our accountability tools, we have developed scorecards, like I said, at regional level, but these scorecards at national and at community level and district level, they drive accountability action and they act as advocacy through data visualization and management functionalities and identification of bottlenecks and the resolution of the bottlenecks. Can I have the next slide, please? Now, what is the history of faith-based organizations in Africa that we could be engaging in this process? Researchers have established that there are more faith-based organizations registered every year in Africa than on any other continent. And we can vouch that faith is central to all communities on the continent, and that faith-based leaders are extremely influential, they are well respected, and they are engaged in the day-to-day lives of their communities. So engaging in health is therefore a given. If we just take two major faiths, there are more Christians in Africa than on any other continent. Countries like Nigeria, DRC, and Ethiopia are amongst the 10 countries globally with the largest Christian populations. And there are more Muslims, that is followers of Islam, recruited in Africa every year than on any other continent. Nigeria, Egypt, and Algeria are amongst the 10 countries globally with the largest Muslim population. Next slide, please. Now, what does this mean for us? It means that we have a unique opportunity as partners to engage with this critical group in various ways in order to ensure that the way in which we engage with communities is more effective. Now, churches around the continent and faith-based organizations are engaged in various ways. This map shows you the different types of engagement by faith-based organizations primarily in primary healthcare, and they work with community leaders, with the community-based organizations, and they work with the community, and members of the community appreciate the service that they give. Next slide, please. I'll just give you a few examples in the next slide of the extent to which faith-based organizations are engaged in health in Africa. In some rural communities, 30 to 70% of all healthcare is faith-based. And faith-based organizations focused on the underserved communities. In countries like Tanzania, 50% of the services in the rural underserved communities is given by the faith-based organizations. And because of this engagement with communities and with people, there are partners such as the Salvation Army, for example, that have used this vehicle. I just wanted to give that example because PMI is a good example, but there are other examples of partners who have come from outside the continent and who use this vehicle to reach communities. They have done this effectively in Kenya, in Tanzania, and in Uganda. And these faith-based organizations, they provide basic treatment, they do disease prevention, they do health promotion, and they do other community health services, like in the areas of mental illness, etc. And they've been critical in the fight against major communicable diseases, like tuberculosis, like HIV/AIDS, like malaria. The main handicap that we have seen is that there is a limited focus on measuring impact and measuring efficiency, effectiveness, and therefore getting better value for the money that is invested by these faith-based organizations and their sponsors and partners. Another limitation has been the limited integration and engagement with the private sector. Now, we have addressed these two areas as areas where ALMA could support countries and therefore the communities, and through the faith-based organizations, and community-based leaders and community-based organizations, get them to own the district scorecards, the community scorecards, and offer an opportunity to fill these two critical gaps that I have just talked about. Next slide, please. Now, how do we do this? We do this, like I said, by working with the countries to develop these scorecards, which monitor the impact of the interventions. They will monitor the performance of both the service providers and the community members themselves and taking care of themselves. I mean, they have to use the nets themselves. They have to present their children to community health workers for early detection and treatment from malaria. And through transparent and wide use of this scorecard, as an advocacy tool, as an action-oriented tool, the scorecard can be used for resource mobilization across a range of actors. And because it is such a versatile tool, we have created a knowledge hub which enables further access to this tool. Next slide, please. Now, there are certain areas which specifically community scorecards have been extremely effective, and they've been effectively used by community health workers. I can give you several examples, but in Ghana, for example, the Community Health Action Plan is developed from the community scorecards. And the community scorecards have been critical in motivating action for new facilities, for registration for community health insurance schemes, increasing in antenatal care attendance in one area from 41% to 79%, and therefore it's increasing IPT coverage for malaria. In Ethiopia, community client councils use the community scorecards, and they have used this to get new maternity wards built, ambulances, get new generators, and address stockouts like in malaria RDTs and in ACTs. So these community scorecards have been very, very versatile, and the communities are actively engaged in using them, and they would be an ideal tool. Next slide, please, for the faith-based organizations as they are for community-based organizations. So in countries like Zambia, for example, in countries like Eswatini, there have been anti-malaria councils that have been formed. These are councils comprising all members of the communities, including faith-based organizations, including the private sector, including community-based organizations, so that they can own the challenge against malaria and use these tools to fight malaria. So malaria councils and funds are an extremely effective vehicle for the community scorecard. There are other, if you need further information, we have the slide deck, which actually has got examples from numerous countries. But the involvement of faith and community leaders and organizations in the fight against malaria in Africa is a necessity to the achievement of the continent's elimination goal. Access to effective interventions has increased remarkably when faith-based organizations and community-based organizations are engaged. Although remaining gaps still remain, we feel that the additional engagement is going to make it even more, have an even more impactful result on our communities. They are the most effective bridge between health systems and our communities. Robust community engagement has ripple effects on the entire health system and will enable universal health coverage. So I would like to thank PMI for introducing this new tool, and also urge our partners and faith-based organizations to use this tool together with the End Malaria Councils and End Malaria funds that are being driven by ALMA in order to strengthen engagement, impact, and the ability of faith-based organizations and community-based organizations to support their people. Thank you.
Thank you very much, Mrs. Joy. Hearing from you is so powerful in terms of accountability using the scorecard. And I know that Alma has been very, very instrumental in seeing us to the point where we are. We thank you so much for this presentation. I'm sure everybody is speaking and they are very energized on how to move forward. As I mentioned earlier, my name is Mariam Nabukenya Wamala, and I'm the co-chair of the RBM Social Behavioral Change Working Group. And I sit together with my colleague, Gabjar. I'm representing the group here. I'm also a member of the National Malaria Control Program in the Ministry of Health, Uganda. The RBM Working Group started out as a community of practice in 2009 and has since grown to a level of membership of about 500. Our most recent meeting, which we held in 2019, had over 130 participants. And just last year, because we couldn't meet, we had a virtual forum where we had over 160 members from 22 different countries over several days. We also hold regular quarterly meetings, and we showcase a number of things that we do as national programs together with our partners. We have a coordination function, which is looks at bringing together national malaria control programs, implementing partners, donors, research institutions, non-governmental organizations, private sector organizations, where we share the best practices and experiences, and we advance our malaria SPC. We also foster the design, implementation, monitoring, and evaluation of theory-informed evidence-based malaria SPC, and advocate for increased resource allocation and partnership building for malaria SPC. And it is through this work that I have come to understand the power of local leaders in malaria control and elimination. One of our driving forces behind the RBM working group is an understanding that malaria interventions depend on human behavior. And over the years, we have had progress against malaria, and it's been dependent on introduction of effective technologies, new drugs, large-scale efforts to make commodities available and accessible to especially those who are vulnerable. We've had progress, and this has depended so much on demand creation for products and services. The appropriate use has been fostered, and change in underlying social norms related to malaria prevention has also been worked on. We consider, for instance, only 2 decades ago, bed nets were not widely used, but as you can see right now, the demand is high and the usage is high in most of the African countries that are endemic. This represents a tremendous cultural and normative kind of change, and we thank in large partnership of everybody in terms of high quality social behavior change, or the SPCC activities that have been done, engagement of everybody through use of leaders and faith-based organizations. Accordingly, social behavior change encompasses health communication, social and community mobilization, with components ranging from interpersonal communication between a community health worker and their clients to multi-level of mass media campaigns. Evidence-based and theory-driven SPC interventions are an integral part of all types of health promotion and disease prevention, and have been shown to significantly improve human behavior. Human behavior and community engagements are essential, very essential in the fight. And most importantly, without these engagements, the fight may not be realized. So we need to maintain and sustain the gains and make sure that we continue with the elimination efforts. Not all social behavior change is equally impactful. However, good social behavior change is research, theory, and system-based. The channels are based on audience needs and communicated in ways that are scientifically known to influence malaria behavior. One proven SPC approach involves the engagement of community leaders and influencers, and that's one of the reasons we are here today. In September 2017, the Health Communication Capacity Collaborative, a USAID Presidential Malaria Initiative supported project, released a literature review of the evidence of the impact of social behavior change interventions. One of the key findings was the power of using community change agents and community leaders, as well as influencers, to influence the uptake and maintenance of malaria-related behaviors. The literature review concluded that such community-led efforts better resonate with the communities they are designed to benefit, and thus increasing their impact. So on that note, the importance of community involvement in malaria SPC is also reflected in the theoretical model that serves as the foundation of the field. And for instance, the socio-ecological model, which we all know and resonate with, urges that individual behavior does not operate in a vacuum, but rather is a complex interaction with all levels of society, community and faith-based organizations with their deep roots in the community are very, very influential across many of those levels, making them well positioned to address an individual's willingness to adopt certain malaria-related behavior. So as you can see, recognizing the critical role they play, SPC has long included faith-based community and local leaders as both an audience and as a channel for interventions. These leaders serve and ensure the needs and values of society, and they are supposed to be reflected as planned. Just to give you an example of how we've been having these very same activities in Uganda, under the USAID's Malaria Action Program for Districts, which is a project that was in a number of districts in Uganda. We engaged religious leaders, local leaders, and cultural leaders. And in our engagement, we would have an orientation with them on key malaria messages. We would then give them a handbook which had messages that would guide them as a point of reference. Then we also gave them a sermon guide, which had verses of either the Quran or Bible that they would relate to the real circumstances that people are going through. And so we would encourage them to mobilize communities using those messages. We would also have them on talk show as panelists to discuss issues related to malaria. And we also encourage them to have a number of household visits to build capacity of household members on what wasn't going well. And in our observation, at the end of the project, we noted that in the 37 districts where the intervention was, we were able to reach about 6 million people in 5 years. And this is a tremendous job, well done, because reaching that number of people is so easy when you have the leaders. These religious leaders can deliver the message very well, and people believe in them. Whatever they say, they believe and act on them. Today, I'm incredibly pleased to be a part of this event and to have an opportunity to support community and faith-based organizations in their efforts to engage in malaria control and elimination. The toolkit that my colleague Anne will introduce shortly features many RBM social behavior change working group resources, including key theories, models, and suggested best practices. We are very excited that PMI, with support from the Breakthrough Action, has launched this toolkit in the recognition of the incredible support the community, faith, and local leaders can play in malaria SPC. I want to take this opportunity to thank you very much for your kind attention. We now want to move to some examples and hear from faith and community leaders in the field. Thanks again.
For the last 9 years, I've been a part of the U.S. President Malaria Initiative team in Guinea. Of all the work that PMI currently supports in my country, I believe that the greatest impact on community is the involvement of faith-based organizations and religious leaders, because these people are very respected by the community. Training the leaders to relay key messages during Friday prayer, for example, has allowed us to reach population that we couldn't reach otherwise. Translating documents to Arabic or other languages when working with different communities also allows for easier access and better outcome. Thank you for this opportunity to speak further about this work. Guinea's National Malaria Control Program has a religious leaders against malaria strategy, which focuses on preparing Muslim religious leaders for their involvement in the fight against malaria at the community level. Through the Stop Polypost project, PMI worked with the National Malaria Control Program and other partners to develop a social mobilization guide, Islam and malaria. The guide includes information about malaria transmission, malaria prevention measures, malaria case management, and the role religious leaders can play in communicating this information to their communities through prayers and sermons in mosques, religious lessons in schools, and religious ceremonies. We then organize workshops in the 2 regions for 40 religious leaders. During these sessions, participants developed sermons in French and Arabic that incorporated malaria control messages into hadiths or sayings of the Islamic prophet Muhammad that were focused on healthy behavior. At the end of these training sessions, the trainers selected the 4 best trainers from each region to train the rest of the religious leaders in their district. In addition to this workshop, through Stop Plus, we have trained more than 1,000 imams throughout 19 districts, selecting the imam of the largest and most frequented mosque to receive training to allow for further dissemination of messages. Since we began working with religious leaders, in 2017, imams have shared malaria prevention and control messages for more than 70,000 people. These messages have included information about the importance of families sleeping under nets every night as a preventive measures and increasing awareness of the need for infants and children under 5 to take anti-malaria drugs to protect them from contracting malaria. Ahead of national campaigns to distribute nets throughout the country, the project produced radio and television spots featuring religious leaders to speak to the advantages of using nets and tell people how to get their nets. So far, religious leaders have participated in 170 interactive radio programs and 92 roundtable discussions to promote malaria control services and products. Religious leaders also work with the project to produce posters and calendars featuring the first imam of the Conakry that are meant to educate citizens about the regular and correct use of nets. Here is an example of the poster that shows Conakry big imam with bed net on hands and saying that he likes protecting his family against malaria. Everyone sleeps on that net. This partnership has had a positive impact on community awareness and participation in malaria intervention. The percent of children that receive all 4 rounds of anti-malaria drug through seasonal malaria chemoprevention campaigns has increased from 72% in 2017 to 89% in 2020. The percent of households that receive nets during mass distribution campaign has increased from 89% in 2016 to 95% in 2019. During the ongoing COVID pandemic, religious leaders have been and will continue to be important partners to the fight against malaria. When distributing anti-malaria drugs to more than 300,000 children during 2020 SMC campaign, Stop Plus face reluctance from some caregivers due to fear of COVID-19. Religious leaders play a key role in putting communities at ease by giving sermons in mosques, taking part in interactive radio programs, and roundtable discussion, and conducting advocacy in household. Thank you very much.
I'm Reverend Canon Emmanuel Chikoya, the General Secretary for the Council of Churches in Zambia, and also a board member of the Zambia Interfaith Networking Group. And so I'm a Chief Executive Officer, and we've actively participated in, among many other things, the fight to end malaria. The Council of Churches in Zambia, following our participation in the Arusha meeting, we were energized, more encouraged to participate in the fight against malaria by collaborating with the End Malaria Council and also working through platforms like Zambia Interfaith Networking Group to mobilize the faith leaders into action and proactive participation in the fight against malaria. So this has been done mainly through resource mobilization internally, and also we've done advocacy and community sensitization programs in a broader sense. In 2019 and 2020, CCZ participated in the implementation of malaria activities ranging from issuing pastoral letters collectively as an interfaith community and participating in the sensitization programs during the World Malaria Day and the SADC Malaria Week, coordinating the orientation of sub-national level orientation and also the provincial one, like the one that took place in Western Province under what is called FLAME. And so we featured also on radio programs, television programs on malaria through our different clergy. First and foremost, we believe we exist to be a prophetic voice with a mandate to have, a prophetic voice to have, with a prophetic, with a transformative impact on church and society. Would like to see a transformed society where there is an enlightened Christian presence, not just about spiritual matters and heaven, but issues of holistic ministry. Holistic ministry means the physical, the economic, the political, and all these other issues are well articulated so that the Christian person is enabled to live effectively and in a dignified manner. Now, because of that, when you promote dignity of a human person, when you promote the sanctity of life, then anything that disfigures or makes that to not to be attainable becomes it attracts our attention in the sense that when people are down, then they can't worship. And when they don't worship, when there's no gathering, then so many other things will not be able to happen, not just at church level, but also at the whole community level. So we are informed by that kind of aspect. We want to see people living healthy, dignified lives. But we are also informed by values such as love, issues of justice, our belief in the triune God, meaning there is a harmony, some kind of fellowship within the Godhead that we should also replicate in society, which helps us to work even beyond what you'd call Christian bodies, because we know that we have common interests, and these will help us to save this person that we are all trying to focus on. And so we will network, collaborate, and work together to the glory of God. As CCZ, I would say our presence is everywhere in this country. You at least find a church. You find a community of believers. And then we bring in the moral authority, a proven track record, a consistency in terms of service delivery. At least there have been challenges here and there, but overall, you can trust the church with resources for the poorest of the poor, and they'll be able to reach. So in the context of malaria, most of the, what I would call the foot soldiers, most of the people that volunteer, the community health workers, you would find they come from one church or the other. And when they're under the church, They'll be more understanding. The critical role would be, we need to create caring and health communities. It is a biblical mandate, not just to pray for people, but to also help them with the relevant message and attitudes and lifestyles that will promote their well-being.
We want to appreciate our presenters. We also applaud the Reverend Emmanuel Chikoya. We know that dignity, love, and justice are very important to human life, and we hope that we have taken this to another level. We love the guidance and the fact that these are biblical quotations that we have to rely on to live life well.
Thank you so much for giving me this opportunity. Good morning, good afternoon, and good evening, everyone. My name is Pascaline Umulisa from Rwanda Girl Guides Association. We are a local NGO with the mission of enabling girls and young women to achieve their potential. Currently, our association counts more than 16,000 girls and young women members. So I would like to extend my appreciation to PMI for this invitation and for their continuous efforts to combat malaria, and especially supporting faith-based organizations and community organizations like mine in this work. Back in 2019, August, I was privileged to attend the brainstorming meeting in Arusha, Tanzania, along with the Reverend Chikoya, who just spoke. So I was with delegation which was made of faith and community leaders here in Rwanda. And at the same time, we were joined by Tanzanians and Zambians in order to plan towards the launch of a pilot All Africa Day of Reflection on Malaria. So this meeting really helped me and my team from Rwanda, which was made of those people from the Interfaith Council on Health, to develop plans for this day and to implement a common day for reflection on malaria back home. It was really an eye-opener for me how a network like ours could really capitalize on its strength to implement a context-specific day of reflection. So we had previously worked with faith-based organizations, but we didn't really use that structure as much. So when we went back home, we together organized the 1 week campaign in 4 districts, involving key stakeholders, including members of the Interfaith Council. This is made of Anglicans, Muslims, Catholic, Pentecostal churches, and it's really, really large. So along with us, we also involved the Rwanda Biomedical Center, which is the government agency accountable for malaria prevention. We also brought in other partners such as the Boy Scouts, the USAID, and the local authorities. So on my side, on my association side, we were joined by the Scouts in the campaign, which made the efforts even more productive. So with our girls and boys, it was really a huge and successful campaign. Before we began the campaign, we made sure that a fact sheet was produced and distributed across our platforms. And the Rwanda Interfaith Council on Health also distributed the package to the leaders. So, and they ensured that all faith-based organizations receive it. So the church leaders received one message to prevent malaria, and it contained all information that everyone could ask for. So the launching took place in all churches, mosques, and which really made the campaign reach to bigger audiences. So as Reverend Chikoya mentioned, it's like all Africans really are really religious. So especially for Rwandans, they attend services at least once a week. So, and the leaders are really trustworthy. So you can imagine the reach and the power of the message that we spread that launching day. So after the launching, it was easy for us youth to conduct our community activities. Our teams of boys and girls organized door-to-door visits. They organized public theaters. They hosted dialogues in schools, in health centers, in the markets. They also hosted TV and radio shows. Additionally, with the support of the local authorities, they distributed and hung mosquito nets in households which didn't have. So as part of the guardian culture, many Girl Guides and Boy Scouts also organized community work. In my country, we call it Umuganda. It usually happens every Saturday of the month to close this campaign. So they organized some street cleaning, they removed water hose, and so on and so forth. At the national level, we closed the Reflection Week in Rwanda district. This is a district located in the Southern Province. And it's on the top of malaria prevalence due to the district's geographical conditions. So overall, our girls and boys, there were more than 1,000. They reached out to 265 households. They hosted 3 TV shows and 4 radio shows, and the story was covered by 3 newspapers. So we estimated that the message has really been received by nearly 10,000 people due to this strong partnership with the community, with the local authority, and then the faith-based organizations. I should also recall everyone here to recognize the efforts and the role of youth in eradicating malaria. So from the campaign, we should see that the youth were really committed to fight against malaria if they received the real and correct information. So we are the future. Give us the right conditions for us to get engaged for this global action. They are no better communicators than the millennial generation. We can be the best advocates by using the power of technology and networks to bring about positive change. Through our campaign, we could really see resilience, activism, and leadership for change and sustainability. So our plans for the future, despite COVID-19, are that we are going to be involved in other campaigns and organize this reflection day and week on an annual basis, and join other campaigns like Draw the Line Malaria, which is currently happening. So I thank you very much for your kind attention.
Thank you so much, Pascaline. What an exciting presentation that was. And thanks to the others for their examples as well. I think it's really inspiring to hear actual success stories from community and faith-based organization work, especially after this summit that occurred in Arusha. So my name is Anna McCartney-Melstad. I've worked with Johns Hopkins Center for Communication Program since 2007 on social and behavior change and advocacy projects based in Tanzania, South Africa, Nigeria, and Cote d'Ivoire. I'm a senior program officer on the Breakthrough Action Core Malaria team, and I'm so thrilled to be a part of this webinar today. PMI, through Breakthrough Action, has developed this toolkit for faith and community leaders after their summit that you heard about earlier. As we have heard from Dr. Panjabi and Joy and our other really interesting panelists, there are so many compelling reasons to include faith and community-based leaders in malaria social and behavior change efforts. Today, I will be doing a brief overview of the toolkit. Can we get the next slide? Thank you so much. A brief overview of the toolkit, but please note again that there's a second, more comprehensive webinar that's going to take place on March 17th, where we're going to explore this toolkit in depth, which is really designed for the end users, namely program managers at the national and subnational levels in malaria endemic countries, program managers of faith and community-based organizations. These national and subnational leaders can then take and tailor and disseminate this toolkit to community level leaders. Since more of this target audience tends to access the internet on their mobile devices, we've optimized this toolkit for use on telephones and tablets. This really allows users to access these tools from the toolkit when and wherever they need them. You can see on this slide the URL and the QR code for the toolkit if you'd like to go and look at it now. Okay, next slide. So the core content of this toolkit falls into 4 main modules: context, malaria actions to promote, using malaria social and behavior change in your work, and advocacy. The content is user-friendly, easy to implement, and easy to digest, and includes many additional resources. I'll go very quickly through the modules now. The first module is the context module. The context module helps users investigate the extent of the malaria problem in their areas and to learn about what ongoing efforts there are and who to coordinate with. Central to understanding the local malaria context is undergoing a situation analysis, which consists of learning about local malaria morbidity and mortality, ongoing malaria activities, opportunities, funding, initiatives, and partners. The next module is called Key Actions to Promote. This teaches users more about malaria as a disease itself and clearly lays out what are the key behaviors that these leaders should promote to prevent and treat malaria. These actions include using and caring for insecticide-treated mosquito nets, preventing malaria during pregnancy, correct care seeking, testing and treatment for malaria, and for those in the areas that have them, indoor residual spraying and seasonal malaria chemoprophylaxis. The module takes users through each thematic area and presents the most important technical information so leaders are prepared to speak correctly about them. As we know, there's many myths and misconceptions about malaria prevention and treatment, and these leaders are very well placed to provide the correct information to individuals and communities. Next slide. The next module takes users step-by-step in planning for integrating malaria social and behavior change efforts into their existing ongoing activities, with many resources to use directly. The 7 steps include aligning organizational values, understanding the audience, identifying organizational strengths and assets, charting the timing of malaria activities, defining those activities, tailoring messages, and tracking projects, the M&E section. Each section contains worksheets and resources that users can use immediately. The module also contains COVID-19 considerations for safely conducting malaria social and behavior change activities. The last module focuses on advocacy. While social and behavior change activities are most often designed to support individual and community level behavior change for malaria prevention and treatment, advocacy activities are usually designed to create an enabling environment for policy change and domestic resource mobilization. And as we've heard from Joy earlier, many countries are implementing the Zero Malaria Starts With Me advocacy campaigns. Faith and community-based leaders are especially well placed to be good advocates for local health and malaria policy and domestic resource mobilization. So this module shows leaders how advocacy can help communities raise political will and add additional malaria resources, and then also better use the resources that are available. And as I mentioned earlier, a more in-depth orientation with faith and community leaders at the national and subnational level on this toolkit will be happening in English, French, and Portuguese simultaneously on Wednesday, March 17th from 8 to 9:30 Eastern time. So this will start at the same time as this webinar did today. So please encourage relevant stakeholders in your networks to attend this webinar. Thank you so much for your time. I wish we had time to go more in depth to it today, but I want to appreciate also all of the fantastic panelists. And I feel just really excited for the next webinar as well. So with that, I'm going to hand it over to Mariam to close us out today. Thank you so much for your time.
Thank you very much. We've had about 155 participants or more on this webinar. We want to thank you so much and thank you over and over again for having joined this webinar today. And please utilize the toolkit. It's available for us to use. We are also expecting to have another webinar on the 17th at 8 a.m. Eastern Time. So that one will be translated in English, French, and Portuguese. So we'll have to listen into to the different languages available. We hope to continue our conversations through online community of practice on Springboard. Please utilize this toolkit. Thank you so much for joining this webinar. I wish you a great morning, great afternoon, and a nice evening.